Welcome to another CME podcast episode from NEI, the Neuroscience Education Institute. In today's CME episode, Dr. Andrew Cutler will be interviewing Dr. Leslie Citrome about the safety and efficacy of VMAT2 inhibitors for the treatment of tardive dyskinesia. For complete CME information, please refer to this podcast's description page or go to nei.global/podcast. Let's listen in as Drs. Cutler and Citrome discuss the efficacy and safety of VMAT2 inhibitors for the treatment of tardive dyskinesia.
Hello and welcome to another NEI podcast. Today's a CME podcast, and it's the third of a three-part series on the topic of tardive dyskinesia. Today we'll be focusing on the efficacy and safety of VMAT2 inhibitors for the treatment of tardive dyskinesia. And with me today, I can confidently say, as one of the world's authorities on psychopharmacology and this topic in particular, my good friend Dr. Leslie Citrome. Hello, Les.
Hi, Andy. Thanks so much for having me here today.
Oh, it's a pleasure, and I look forward to our conversation. But you know, Les, before we jump into specific treatments, I still feel like there's a lot of misunderstanding out there about how to recognize tardive dyskinesia and how to treat it appropriately. There are still many clinicians who tell me that they're being trained, for instance, that benztropine, an anticholinergic, is an appropriate treatment for tardive dyskinesia. So maybe you could just start out by helping us to recognize TD, and why is it so important to distinguish it from other drug-induced movement disorders?
Yes, it has been challenging, hasn't it? TD's been around for a very long time, and for a very long time we've had no treatments for it. And so it's been extremely frustrating. We've tended to overlook it because we don't have anything up until recently to offer. We were also lulled into complacency with the second-generation antipsychotics, falsely believing that it would lead to no TD at all. As it turns out, second-generation antipsychotics do have a lower propensity for acute drug-induced motor movements, such as drug-induced Parkinsonism or dystonias. But TD is still there, and many of our patients who are exposed only to second-generation antipsychotics would get TD. But unfortunately, we've tended to not think about it, and we overuse things like anticholinergic treatments, thinking it would be good for everything. So it is a problem. As you've identified, benztropine is often used in people with any kind of movement disorder, when in fact, when we look at the data, it can make TD worse.
Yeah, you know, it's interesting. I think you're absolutely right, Les. I think that for so long we had nothing truly effective to treat TD, and yet here we had medicines like benztropine that did work for certain drug-induced movement disorders like Parkinsonism and dystonias, and so we incorrectly assumed that, hey, it works for anything that moves.
Yeah, and so now we're faced with a difficult situation that we need to correctly identify TD, contrast it with drug-induced Parkinsonism, and treat accordingly. Treatment for one may worsen the other, I like to say. The treatments we use for drug-induced Parkinsonism, namely benztropine, can make TD worse. Also, the treatments for TD, VMAT2 inhibitors, can make drug-induced Parkinsonism worse.
Yeah,
I think the issue here is not to have drug-induced Parkinsonism to begin with, which is achievable. Unfortunately, getting rid of TD entirely is not. So we're in a world now where we can manage DIP pretty well, get rid of it pretty well, but we still have to deal with the TD.
Yeah, in some ways, they're kind of a yin and yang, aren't they? I mean, it's literally almost the opposite psychopathology, and the treatments are literally doing the opposite with respect to dopamine tone, if you will.
Yeah, they are the opposite. One way to keep this straight in our heads is to think of DIP as a hypodopaminergic state. So drug-induced Parkinsonism, if we think about it like Parkinson's disease, there's not enough dopamine. When we use antipsychotics, we block dopamine D2 receptors, hence a hypodopaminergic state. On the other hand, tardive dyskinesia is a hyperdopaminergic state. There is too much dopamine signaling when we don't want it. And that's as a consequence of the upregulation of D2 receptors from being exposed to dopamine receptor blocking agents over time.
I see. And so obviously I'm going to want to do the opposite with my treatment. So the anticholinergic medications, I'm assuming, increase dopamine tone.
Yeah, so anticholinergics bring about an improvement in drug-induced Parkinsonism, but they will make TD potentially worse. So you don't want to give it in someone in a hyper-dopaminergic state.
Yeah, I mean, you're pouring gas on the fire, aren't you, if you're increasing dopamine into this hyperdopamine state? So this leads us to what we're going to be talking about today, which is VMAT2 inhibitors. And I guess we need to start by understanding what is VMAT2.
Well, it's an interesting concept. VMAT2, vesicular monoamine transporter type 2, is that protein that allows dopamine within a neuron, in the cytoplasm of the neuron, to enter into a synaptic vesicle. So VMAT2 is necessary for dopamine to be incorporated into the vesicle. And that's important because neurons work by releasing the contents of these vesicles when the neuron fires. So if we all remember our basic physiology in the brain, when a neuron fires, it releases the contents of synaptic vesicles into the synapse. And in a dopaminergic neuron, the vesicles are filled with dopamine. Now, the dopamine has to get into that vesicle in the first place, and VMAT2 is the transporter that does exactly that.
So the V is for those vesicles that contain, so dopamine is made in the presynaptic neuron, and then it has to be packaged into these vesicles, and the transporter is called vesicular monoamine transporter.
Right. So it exists and its job is to take dopamine from within the cytoplasm of the neuron and bring it into the synaptic vesicle so that when the neuron fires, it's going to release vesicles filled with dopamine.
So monoamine in this case refers to dopamine specifically, right?
Right. There are other monoamines, but we're talking about dopamine.
Yeah. And why is it called VMAT2 as opposed to VMAT1?
Well, interesting question. VMAT1 also exists elsewhere. And in the old days, we had a VMAT inhibitor. It was called reserpine.
Oh, yeah.
And it inhibited both VMAT1 and VMAT2, both centrally and peripherally. It also did it irreversibly. So reserpine actually was a depleter of monoamines. What do I mean by that? It depleted dopamine, but it also depleted serotonin and norepinephrine and led to some people getting depressed.
I see. And so VMAT1 is more peripheral, VMAT2 is more central, and that's obviously what we're interested in here. So now we have drugs that are more selective for VMAT2.
Yes, that's a big advance because we don't want to get into trouble peripherally. We also don't want to get too much depletion. Reserpine was an irreversible inhibitor, which is not a good thing. You want something that's more reversible. You want to decrease the amount of transport into the vesicle in a reasonable way and not permanent. And so a reversible VMAT2 inhibitor, such as valbenazine, for example, will do just what we want.
I see. So reserpine, I guess we should tell people, has an interesting history. It was originally developed, I believe, as a potential antipsychotic because of this decreasing of dopamine in the synapse.
Yeah, and it was then used as an antihypertensive.
Yes.
And
peripheral effects, I believe, yes.
Yeah. And actually, I used to work at a VA hospital in the 1980s, in the late 80s, where there was an entire ward in this long-term care facility operated by the Department of Veterans Affairs. It was actually the Veterans Administration at that time. And an entire ward where everyone was on reserpine for their treatment-resistant schizophrenia.
That is really interesting. That's fascinating. All right, well, let's move forward. What was the first of the VMAT2 inhibitors approved in the United States?
So if we go into some ancient history now, we have tetrabenazine, which was a VMAT2 inhibitor, reversible, approved for chorea associated with Huntington's disease. It's been available for a very long time worldwide, and it got approved as an orphan drug here in the U.S.
In 2008, I believe.
Yeah, so a while ago, but before then, I recall being able to import it from England as part of a study being conducted in TD. And you see, we were thinking about that even then. But it became approved in this country for a very specific purpose, and then access to it became much more difficult to treat people with TD. The tetrabenazine is interesting in terms of its efficacy, but tolerability was kind of challenging. You needed to dose it multiple times a day, and it was associated with some side effects that were difficult to manage. And so not ideal, plus very expensive as an orphan drug. So in contrast to the early days when we had it as part of a protocol where we can actually buy it from outside the US for not very much money, now the only way we could have gotten it was through paying for, which was not possible.
So what you're saying, of course, is there was data that tetrabenazine was effective for tardive dyskinesia, unless you're the first person who taught me that it was actually approved in a few countries for the treatment of TD before it became available formally.
So in the U.S., it was approved specifically for chorea-associated with Huntington's disease, but in other jurisdictions, in other countries, it was actually approved for TD as well. And so the world has some familiarity with it and experience.
So this mechanism then, of course, looks like it's effective for TD. And as you mentioned, the problem with tetrabenazine is that very short half-life. That means you have to take it 3 or 4 times a day. And of course, pharmacokinetically, the blood level now is whiplashing up and down, if you will, and a lot of tolerability issues with those high peaks.
Yes, so this is always an issue with medicines, right? If you have too high a peak, you might have peak-associated adverse events. And you can make that go away by developing a different kind of formulation or a different way of delivering the drug that is more smooth.
Right. Okay, so now let's fast forward to 2017. There are 2 medications that are essentially derived from tetrabenazine that get approved.
Yes, there are. And so this was a major advance. I never thought I'd see the day where the FDA would approve treatments for TD, and there were actually 2 of them. That's great because that increases the level of interest and excitement about this.
Sure.
And they both build upon the tetrabenazine story, but in 2 very different ways. One of the ways of doing it is straightforward. You take the tetrabenazine molecule and you deuterate it, which means you substitute deuterium atoms for select hydrogen atoms on the molecule. And the deuterium bond that it makes with carbon is much stronger than the hydrogen-carbon bond. It takes more energy to break that bond. So you change the pharmacokinetics of the drug by altering it by substituting deuterium at key points. And so you have deuterated tetrabenazine now. It's called duotetrabenazine and approved for tardive dyskinesia. It has a longer half-life. It's given twice a day and basically does what tetrabenazine does, but perhaps in a more tolerable and easier to use fashion. Now, another way of approaching the issue is you look at what are the active ingredients of tetrabenazine in its metabolism. And there are 4 metabolites of tetrabenazine. A couple of them have more activity than the other 2. And one way of developing a new drug is to see, can you develop a drug that then gets metabolized to one of those very active metabolites that does the job you need it to do? And hence, valbenazine itself has a VMAT2 activity, but its primary active metabolite is doing much of the heavy lifting. And by having this approach, you have a half-life that is long, and a drug that can be given once a day.
So there are 4 active metabolites of tetrabenazine, as you mentioned, and 2 of them, the plus alpha and the plus beta, seem to have more affinity for the VMAT2 transporter. And so by selecting the plus alpha, I believe, is what valbenazine, and they covalently bound a valine, an amino acid. So that seems to be the trick there. It's interesting chemistry.
It is very interesting. You want the right metabolite. So plus alpha, plus beta. You don't want minus alpha, minus beta. And you can do this in various ways. So the valbenazine approach is one way. The duotetrabenazine approach is different. But the end result is you have a predominance of the metabolite that you need that hangs around for long enough, and you can dose it reasonably. So twice a day is reasonable. Once a day, I think, personally, is preferable, but it's not like the 3 or 4 times a day of tetrabenazine.
You know what's really fascinating? Newer research has shown that tetrabenazine and deutetrabenazine do not have a lot of the plus alpha metabolites circulating. It's actually predominantly the plus beta, which also has affinity for VMAT2. So in essence, they're 2 different of the active metabolites. They're kind of 2 different chemicals.
They are. So this brings up an interesting question. They're not the same. They're
Yeah,
not interchangeable, which
right.
is, I think, a good thing.
I agree.
Because in clinical practice, when something doesn't work, you want to try something else. Here's an opportunity to try something else that is not the same. So
Yeah.
I'm quite thankful to have two choices here.
I couldn't agree more or less. And I think that one of the take-home messages for our audience is if somebody doesn't respond ideally or tolerate one of these two medicines, it's very reasonable actually to try the other one.
Absolutely. So I never want to give up on someone with tardive dyskinesia. It's a very disabling disease, a disorder, manifestation of being exposed to antipsychotics usually. And people can have some quite significant functional impairments like buttoning buttons, tying their shoelaces. But there's also the issue that they feel stigmatized with these movements. And if a person's aware that their lips are moving and their tongue is moving around, they become quite embarrassed about it and don't want to go out in public anymore and become more isolative. And
Mhm.
for people who have no insight into their movements, which we do see from time to time in people with
Yes.
schizophrenia,
Yes.
where they deny their illness and they deny their movement disorder, it's very stigmatizing. People look at them, stare at them, point their fingers at them. Their family doesn't want to bring them to the mall anymore because everyone is looking at them.
Mhm.
So it's very difficult to reintegrate someone into the community when you have a stigmatizing physical manifestation of something.
Yeah, well said. I mean, just looking at someone, you can't necessarily tell they have a mental illness, but when you have this going on, it really does stigmatize. And I like to say, TD is more than just a cosmetic problem, isn't it? It can affect people in physical and emotional and social ways, as you've talked about. So
You know,
there really is a good reason for us to consider treating.
absolutely. And it's important for us to, when we identify these movements, to find out how it has affected the individual experiencing them. Have they altered their behaviors? Have they become less social?
Mhm.
And what about the physical issues? Do they have sores in their mouth, for example?
Mhm.
Sores on their feet, on their toes, which
Mhm.
if they're moving around involuntarily and they're wearing shoes and socks all the time, it's going to have a consequence.
Oh, sure. And I've seen patients with dental issues and all kinds of consequences, like you said. So I guess it's very important to do a very thorough and careful assessment, which brings us to, of course, the topic, one of our topics today, which is how to individualize treatment regimens. And I think we've talked a little bit about these two FDA approved options are different and do allow us perhaps to individualize based on a variety factors. Les, I think we should connect the dots, though. Let's connect the dots on how is it that inhibiting this transporter, which is intracellular, how does that help tardive dyskinesia clinically?
Well, we have to start at the beginning. Why do people develop tardive dyskinesia in the first place? We know that dopamine receptor blocking agents, such as antipsychotics, work their magic by blocking postsynaptic D2 receptors in the ventral striatum.
Mm-hmm,
And that's the seat of psychosis, so to speak.
mm-hmm,
It's believed that excess dopamine signaling in the ventral striatum results in hallucinations and delusions.
mm-hmm.
By blocking those postsynaptic D2 receptors with an antipsychotic, we reduce delusions and hallucinations. And this is how antipsychotics are thought to work, at
Now
least the
that's
ones that are available today.
no, that's the limbic system, right?
Right,
The mesolimbic system. Okay.
right.
Got
So the circuit itself is from the ventral tegmental area
it.
to the ventral striatum.
Got it.
But there's collateral damage, Andy.
Mhm.
Collateral damage in that dopamine D2 receptors in the dorsal striatum are also blocked.
I see.
And the dorsal striatum specifically is that part of the brain that controls our movements. It's also been called the neurologist striatum or the motor striatum
Mhm.
for that purpose. So by blocking dopamine receptors there, and this happens when you block the dopamine receptors in the ventral striatum, the ones in the dorsal striatum also get blocked,
Mm,
you're going to see drug-induced Parkinsonism.
mhm.
And that's the explanation for that. Now, these receptors in the dorsal striatum don't take this lying down, so to speak.
Yes,
And that neuron where these receptors sit actually reacts to the blockade by producing more D2 receptors.
I see. So it's
So actually, yeah, it's fascinating that the DNA mechanism of the neuron gets into gear and produces more D2 receptors. Moreover, these D2 receptors that are created happen to be a bit more functional. So you actually sprout new D2 receptors on that postsynaptic D2 in that scheme there. And that neuron will have more D2 receptors there that actually are higher in functioning in terms of efficiency.
Mhm.
And so they become sensitive, and you have a
Nice.
hypersensitive state in the motor striatum.
So
So
it's almost like the brain's trying to overcome or compensate for this D2 blockade over time.
yes, for some people, it does it all too well. And it doesn't take much dopamine then to trigger a dyskinetic movement.
I see.
And one of the approaches that we used for years is to just block more of those D2 receptors.
Right.
Just increase that dose of that antipsychotic, and
Mm.
you have increased blockade, and that will mask the
Mhm.
TD.
I see.
But it's like kicking the can down the road
Mm.
because that upregulation process is unrelenting.
Mm.
And eventually there'll be, again, more D2 receptors, and they'll predominate, and you'll have a return to the supersensitive state.
Now, Les, this theory, of course, is very reasonable, but what makes me think there might be a little more going on is the fact that when you stop a D2 blocker, these receptors are plastic and they do tend to go back to the native state, and yet TD doesn't always go away for everybody. So perhaps you're starting a cascade of events, or there's other things involved as well.
I think so. Not everyone develops TD, and not everyone develops persistent TD once
That's right.
you remove the antipsychotic or dopamine receptor blocking agent, but some do.
Mhm.
And so there have been some genetic vulnerability genes that
Mhm.
have been identified.
Yeah, so that's obviously one day down the road, we might have really individualized treatment when we can figure out who that is that's at risk. Okay, so now we are inhibiting the VMAT2 transporter, and how does that help?
Well, rather than blocking more of those D2 receptors by increasing the dose of the antipsychotic, we can approach the problem another way.
Mhm.
What if we can decrease the amount of dopamine that's released by the dopaminergic neuron, particularly in the motor striatum?
Mhm.
So this is the circuit from the substantia nigra to the dorsal striatum, and dopamine is being released from those dopaminergic neurons. What if we reduce the amount of dopamine that's released? Wouldn't that take care of the hyperdopaminergic state? That's the thought behind VMAT2 inhibitors.
Mhm.
So remember, VMAT2 inhibition results in less dopamine being incorporated into the synaptic vesicle. So when the neuron fires and dopamine is released in the dorsal striatum, less dopamine is released because
I
there's
see.
less dopamine in the vesicle. You're
Mhm.
shooting blanks, so to speak.
Yes. And so this then sounds like it helps to re-regulate or rebalance this out of balance dopamine system.
Yes, it does so. It reduces the amount of dopamine available in the dorsal striatum specifically and decreases the chance of a dyskinetic movement from occurring. And it is an enduring effect because you're not blocking D2 receptors as you would with increasing the antipsychotic. You're not altering the upregulation process that would occur otherwise by fiddling around with the antipsychotic.
Well, this is really fascinating. So this is a fascinating theory, of course, but what is the clinical evidence that these things actually work?
Yes, it's an interesting theory. I always like to say the proof of the pudding is in the taste. And so I don't care what story you come up with to explain a drug effect, you have to demonstrate a clinical trial that demonstrates that it works.
Yes.
So this was done with the VMAT2 inhibitors in several studies.
Mhm.
And classically, what is done is you take patients with moderate to severe TD, you randomize them to receive either the drug of interest or placebo, and you measure the dyskinetic movements over time. The studies for valbenazine were done and demonstrated efficacy, and I'm going to talk about in particular the pivotal study that led to its approval.
Mhm.
Connect 3. This was a study where patients were randomized to receive either valbenazine 80 milligrams a day, 40 milligrams a day, or placebo,
Mhm.
and followed for 6 weeks. What was measured here was actually the abnormal involuntary movement scale, the
Mhm.
AIMS. Yes, that very same scale that we use in the clinic is used in clinical research for tardive dyskinesia.
Well, that's
And
interesting, Les, because this is maybe one of the few rating scales that we use in research that is actually very clinically practical and is widely used clinically.
Yes, so we should all be able to understand it.
Yes.
So that's terrific. What they specifically looked at was the sum of the scores for items 1 through 7. So the AIMS items 1 through 7 measure actually the movements themselves in 7 different muscle groups.
Mm-hmm.
Or in the face, 1 for the upper extremities, 1 for the trunk, 1 for the lower extremities. A total of 7 items,
Mm-hmm.
each of them scored from 0 to 4.
Mm-hmm.
0 means no movement. 1 means I don't know if a movement is there or not, but I'll be sure to check it more carefully next time. A 2 means the movement is there, and anyone who is trained will identify it. A 3 is a movement that even people who are not trained will be able to identify it. And a 4 is people can identify it from across the parking lot. 0 to 4.
Mm-hmm.
And you sum up these 7 items, and you come up with a total dyskinesia score, 0 to 28.
Mm-hmm.
I've never encountered someone who scores a 28 because that would mean a 4 on those 7 muscle groups, just not possible, not compatible with life.
Yeah.
But a score of 10 or 11 is certainly clinically significant and relevant tardive dyskinesia.
Yes.
And on average, the people participating in Connect 3 had an average score of about 10.
Mm-hmm.
So they were followed over 6 weeks to see if this total dyskinesia score would go down.
Mm-hmm.
And it did. The ones who were randomized to placebo showed no change. The ones who were randomized to 40 milligrams a day actually did show improvement, but those who were randomized to 80 milligrams a day showed an even larger degree of improvement with an effect size close to 1.
Oh my.
What does that mean? It means close to 1 standard deviation difference from
my
placebo.
Goodness. That's a very large effect size, is it not?
It's a huge effect size. So it's very encouraging.
Mm-hmm.
For the 40 milligram dose, the effect size was half that. But that's still pretty robust.
Still very respectable, yes. It's very clinically meaningful.
But let me ask you, Andy, what would you prefer, effect size of 1 or a half?
I'm greedy, Les. I would take the higher one.
Yeah, so would I.
More.
And that's why I always advocate 80 milligrams seems like the best dose when you compare groups of patients. Now, in the real world, some patients on 40 will do just fine. But if they still have residual symptoms, I want to bump that dose higher. There's now a 60 milligram dose available that through modeling shows an effect size between 40 and 80 in terms of where it fits. And the nice thing about VMAT2 inhibition is that it works right away, essentially. And you can detect a difference in the clinical trials as early as 2 weeks, although the primary endpoint is at 6 weeks. You know, I do want to mention something else about this study, which not everyone fully is aware of. These ratings were done through videos. Imagine that. This predates, of course, the public health emergency. Predates what we've been forced to do during the pandemic, that is, living in a virtual world. Back then, this is how it was done in assessing TD. Now, for sure, people were going through the AIMS procedure remotely and filmed in a nice studio where, you know, it was ideal lighting and room. And the experts who were rating the videos were experts in movement disorders. So it was ideally done. And, you know, they were blinded to what, of course, the patient was randomized to, but also blinded to when the assessment was recorded. Baseline, week 2, week 4, or week 6.
I see. So they could be really objective here.
Exactly. So I have a high degree of confidence that this was truly blinded.
You know, Les, I was an investigator on this study, and we would set up a special room, as you said, with a white background and a special camera. And so you're right that we really did try to get good quality. But the fact is that using a sort of form of telemedicine, people were able to do an AIMS exam.
Yeah, even before it was popular.
Yeah. So what was the magnitude of improvement here? What was the absolute change in the AIMS?
So about 3 points from baseline. That's about 30%. What I find helpful is to look at the number of people who've improved by at least 50%.
Okay.
And then I come up with something called number needed to treat. How many patients needed to be randomized to valbenazine 80 versus placebo before expecting one additional person who had an improvement of at least 50%? And that number was 4.
Oh, my.
Which is actually very impressive.
It is.
Most of our treatments in psychiatry aren't as good as that.
Yeah, lower number, of course, is better. Less than 10 is clinically meaningful, yes.
Yes, and the outcome that we're looking at is a 50% reduction,
Mm,
which is a spectacular decrease in
that's a
tardive dyskinesia. Because, sometimes I'd be happy if there's only 1 point decrease in the dyskinesia score. Why would I say that?
mhm.
Let's say they scored a 4 for the tongue and it went down to a 3. That may make all the difference, or better, from a 4 down to a 2, in which case I've changed their lives.
Yeah, very much. That's very interesting. Okay, so how about now if we talk a little bit about the data for deutetrabenazine, the other VMAT2 inhibitor?
So deutetrabenazine was evaluated in 2 short-term studies lasting 12 weeks in duration. One of them used flexible dosing, the other one used fixed dosing.
Mm-hmm.
In the flexible dose study, called the ARM study,
Mhm.
patients were randomized to receive either deutetrabenazine or placebo, and their dose was increased to what the clinician investigator thought was ideal in terms of response plus tolerability. And the average dose hovered close to 40 milligrams a day when all was said and done. This was a 12-week study, and the results demonstrated superiority of deutetrabenazine over placebo with a change from baseline, also, I think, about 3 points, if I'm
Yeah.
not mistaken.
No, I think you're right. A very
Yeah,
similar magnitude of change.
very similar. And they also the manufacturers conducted a study using fixed doses
Mm-hmm.
where patients were randomized to either 12, 24, or 36 milligrams a day to tetrabenazine and contrast that with placebo and observe for a period of 12 weeks. And the primary goal was to demonstrate that 36 milligrams a day would be superior to placebo, and it was.
Mm-hmm.
But 24 milligrams a day was also about the same in terms of magnitude, in terms of improvement. And so that too was interesting. But, it turns out that in long-term outcomes and observations that usually a higher dose would be required on average, but you do get some patients who benefit from a lower dose. So the same story as with valbenazine. You get some patients who do well on 40, don't need higher,
Mm-hmm.
but you get more bang for the buck if you go to 80, at least when you look at groups of patients.
For the valbenazine. Now, do you know the mean dose, so the average dose in the first study, the ARMS study, when it was
So
flexible?
about close to 40 milligrams a day.
Interesting.
Yeah.
Okay.
So I would tend to go up, and there is a titration pack available now for that product, which makes it a little easier to do so. But it does take a bit of time to reach that dose. Now, the outcome that was being measured was again the Ames dyskinesia score,
Mm-hmm.
the sum of the first 7 items.
Mm-hmm.
And again, the way it was evaluated was through videotapes
Mm-hmm.
or recordings and evaluated by experts in movement disorders.
And again, as we said, the magnitude of change was about a 3-point improvement. But the mistake would be, of course, to say, well, 24 and 36 were the same, so I don't have to go higher than 24. This study wasn't designed to compare those two doses to each other, but to placebo. And we all know there's no one-size-fits-all dosing, and some people need more.
Absolutely. So I'm never satisfied. I want those dyskinetic movements to disappear, and I'm not satisfied with good enough.
Mm-hmm.
And so I will push the dose of either drug.
Yeah.
An interesting observation is when you pool together 40 and 80 milligrams a day of valbenazine and compare that with placebo, you get a number needed to treat of 5.
I see.
Not too shabby.
Mm-hmm.
You know what the number needed to treat for deutetrabenazine was at the efficacious doses of 24 and 36 from the fixed dose study
I'm
for the
guessing
very same outcome?
it's in the 4 to 5 range.
It's a 5.
Yeah.
So I'm very pleased with the results of these trials. It tells me that VMAT2 inhibition is a way to go as a mainstay treatment to manage tardive dyskinesia.
Now, we don't have, of course, any head-to-head studies suggesting one is more efficacious than the other, but we do have these studies that show they both have a similar magnitude of improvement. And so how is a clinician to decide then how to individualize, how to use these two tools?
Yeah, so basically, I like having 2 options because, as we spoke before, if one doesn't work, you just try the other.
Mm-hmm.
And that may work for some people, so that's good.
Mm-hmm.
But they're essentially distinguished by how they're taken. Valbenazine is once a day with or without food. Deutetrabenazine is twice a day with food. Valbenazine, the first dose that you give, 40 milligrams a day, may be efficacious, but you do want to go up to 80 in general under most conditions, although not all. And you can do that by day 8.
Mm-hmm.
So they can be on 40 for a week, then you go to 80. And that's how it was done in the clinical trials if they were randomized to 80 milligrams a day. You can do that in practice. With duotetrabenazine, you start at 6 milligrams BID, but that will not be good enough.
Mm-hmm.
And you only get to 12 BID by day 15. So it's a little slower process. But then again, put this into broad perspective. TD is a long game here.
Yes.
You're treating a chronic condition. They're not psychiatrically acutely ill, because that's not a good time to start treating their TD.
Mm-hmm.
And so you can take the time and care to get to a medicine that they're willing to take and that will work for them.
Mm-hmm.
So that's the major differences: titration, and as well as the how many times a day do you need to take it. There are some other differences in terms of the route of metabolism.
Mm-hmm.
With valbenazine, the route of metabolism is by both 3A4 and 2D6 isoenzyme systems. And for duotetrabenazine, it is only the 2D6. So there's going to be some differences in terms of drug interactions.
I see. So more to think about with valbenazine, because you have to be concerned with the CYP3A4 in addition to the 2D6. I see.
Right. This really only comes into play realistically with 3A4 inducers,
Mm-hmm.
in which case, the maximum dose of valbenazine is 80, and we can't go higher for actually more practical reasons than anything else. So the inducers mean that you have less of valbenazine for any given dose. And so how do you compensate for that? You would want to give more than 80, but you can't.
Right. So the package insert actually says it's not recommended for those, although, as you said, you would think you could just adjust. But
yeah, well, let me play devil's advocate for you. Let's say I do want to adjust for it and I want to give 160. Why can't I? I can't get it reimbursed.
Yeah, that's the problem. Because that would be 2 pills, of course.
Yes, that would be 2. So I don't know. It's never been tested that way. So this is all conjecture on my part.
So fortunately, it's not contraindicated. And then I guess taking into account, 2D6 and 3A4, this is something I look up in the package insert, but you would make adjustments based on inhibition or induction, as you said. Well, inhibition is really the one you would adjust for.
Yeah, so if, let's say someone is on paroxetine or fluoxetine or bupropion, those are 2D6 inhibitors, and so I would give 40 milligrams a day of valbenazine under those conditions. What if we know that they are poor metabolizers, 2D6 poor metabolizers? Then again, 40 milligrams would be the preferred dose.
Makes sense. I want to get into the specifics maybe of one versus the other as far as these amenities of care, the way they're used, the things to worry about. Let's just take a step back and say, what was the safety profiles like in these studies we're talking about here? Is there something I need to be concerned about that might limit me from pushing the dose higher?
Well, this is my favorite question, because the ultimate test of tolerability is if someone has to discontinue because of an adverse event in the clinical trial.
Yes.
So for both of these drugs, when you count up the percentage of people who discontinued because of an adverse event on drug of interest or on placebo, the difference in rates is 1%.
Oh, my.
Which gives us a number needed to harm of 100.
Oh,
It took 100 people to be randomized to one of these VMAT2 inhibitors versus placebo before expecting to encounter one additional patient who had to stop because of an adverse event. So that's hardly anyone. When you look at the number needed to treat for robust response, and it's a 5, for every 5 who are randomized to either one versus placebo, before you encounter one additional person with robust response, a 50% reduction or more, 5, you can do some interesting math here. So Andy, what's 100 divided by 5?
That would be 20.
20. You're 20 times more likely to encounter robust response than have to stop the drug because of an adverse event. 20 times more likely to get success rather than abject failure. And you'll know this in a relatively short period of time. So in my mind, this is a terrific risk-benefit equation, and there's no reason not to try these agents.
Boy, I like those odds, yeah. Yeah, but as far as the side effects, for valbenazine, the number one was
Yeah, number one was sedation somnolence, 11% for any dose of valbenazine, 4% for placebo,
Hmm.
a difference of 7%, a number needed to harm of about 14.
Hmm.
So you're not going to encounter that all that often, but
Hmm.
if you do, my preference is to dose it at night and
Yes.
perhaps adjust the dose. And if it's just too much of an issue, then try the other agent.
Right. Now, the good news now, as you mentioned, is we do have that in-between dose, the 60 milligrams, which might allow you to, adjust down, say, from the 80 and perhaps get a little better tolerability.
Yeah, so it's nice to have three different doses.
Yeah.
Although ideally, I want to push the dose to 80, and I will never waver from that. I do understand some patients
Mhm.
may not tolerate a higher dose, and you may have to go to a lower dose. I don't think this would happens with great frequency, but it's nice to have a fallback position, if you will. And then you always have the occasional patient whose TD completely goes away on 40, and for many instances, we keep them on 40 for a month only because of the way our practice is set up, where we start the medicine and then we reevaluate a month later.
Oh,
Well, in that 1 month, that 40 milligram a day dose may have resulted a robust reduction in TD to the point where you don't want to go up higher.
sure.
There's no point.
Well, particularly in someone who is a poor CYP2D6 metabolizer, they're getting an exposure that's the equivalent of a higher dose, I guess.
Right. And we didn't even know that because we don't identify poor metabolizers routinely in practice.
We often don't. Okay, and then the side effect profile for deutetrabenazine was also very impressive, was it not?
It was. So there's actually some interesting data there because this is a drug that has to be titrated. This is how it was designed and
Yes.
studied.
Yes.
The percentage of patients who had to have a dose reduction because of an adverse event on deutetrabenazine was 4%.
Oh my.
For those on placebo, it was 2%.
Oh my. Very.
So a difference of 2%, which is a number needed to harm of 50. It
Mhm.
took 50 patients to be randomized to deutetrabenazine versus placebo before you expect to encounter one additional patient who had to have a dose reduction because of an adverse event. It's
Interesting.
not going to happen very often. So very highly tolerable agent. When we look at the adverse events that are the most common, we'll use a threshold of 4% or greater and twice that of placebo. There are only two of them, nasopharyngitis and insomnia. Both of those were reported at 4% for at a higher rate than what was observed for placebo.
Only 4%. That's quite interesting. So these medications, we forgot to mention that tetrabenazine, something like 40 to 60% of patients get somnolence, dizziness, or agitation. And these are side effect rates that are much lower.
Yeah, so also different populations too. So
That's true. That's true.
need to be clear. When you test deutetrabenazine, for example, in a Huntington's population, they don't tolerate it very well. At least they tolerate it well enough, but those with TD tolerate it much better.
Yeah.
And that may be because of the brains of people with Huntington's disease are already quite damaged with this progressive neurodegenerative disorder. And rates of depression are extremely high in people with Huntington's. In fact, there's a box bolded label warning for deutetrabenazine regarding suicidality, specifically regarding Huntington's.
But to be fair, it was far better tolerated in the Huntington's patients than tetrabenazine was.
Oh, yes.
And there was really not much of a signal for depression or suicidality in the deutetrabenazine studies for Huntington's, but this warning was inherited because tetrabenazine had the same indication. So when you get the same indication, you inherit some of that safety information.
Yes, agreed. I think it's important to highlight that warning for Huntington's only to
Yes. Yes.
make sure everyone with Huntington's is screened and treated appropriately for depression. It is just so common.
Totally agree. And this is the basis of one of the differences between the two medications and contraindications. Deutetrabenazine has an actual contraindication for Huntington's patients with inadequately treated depression or suicidality, whereas Ingrezza does not carry that warning and is currently not approved for Huntington's.
Yeah, that may change though. If what changes everything in terms of indications is if a study's done
That's right.
and it's positive, it's incorporated into labeling. So wouldn't it be cool if valbenazine was also approved for Huntington's?
I think it would be great, again, to have more options,
Yes.
especially for such a serious illness. So at this point, valbenazine does not have a bolded box warning, whereas deutetrabenazine does, as we mentioned. Interestingly, though, there are a couple of other contraindications for deutetrabenazine that have to do with hepatic impairment and other VMAT inhibitors and monoamine oxidase inhibitors. But those are not contraindications for valbenazine, interestingly. It only has one hypersensitivity. So that's fascinating, isn't it, these differences?
Yeah, so hepatic impairment, that contraindication is as a result of what's known about the molecule.
Mm-hmm.
And so those things can change over time, provided studies are done. The contraindication regarding other prescribing of other VMAT2 inhibitors, I think that's common sense.
I would think so too. I would
yeah.
think you should use that as a guide for valbenazine as well. I wouldn't.
Yeah, so I wouldn't combine VMAT2 inhibitors together. I don't think you know what's going to happen. There's also the recommendation to not use MAO inhibitors in conjunction with VMAT2 inhibitors.
Yes.
And when you think that through, it makes a lot of sense. What does an MAOI inhibitor do? Well, it prevents the degradation of dopamine in the cytoplasm. What does a VMAT2 inhibitor do? It prevents the incorporation of the monoamine into the vesicle. So what happens to all that dopamine?
Yeah.
Can't be good.
Well, monoamine oxidase is not only extracellular, it is intracellular. And
yes.
It could be a problem because you're inhibiting the metabolic route. Well, as far as warnings, there are some interesting similarities and differences. Valbenazine has 3 warnings: somnolence, QT prolongation, and Parkinsonism. And deutetrabenazine has the same 3, but interestingly, Les, it has a warning for NMS and a warning for something that didn't show up in the tardive dyskinesia studies really much more than placebo. That's akathisia, agitation, and restlessness.
Yeah, so some of that is language from tetrabenazine.
I see.
And, basically, deutetrabenazine was approved through a regulatory pathway that obligates the sponsor to include language and labeling for the original compound.
Yes, exactly.
So they're stuck with it.
Well, 2 others, by the way, I forgot to mention, are increased prolactin and binding to melanin-containing tissues. And I think you're right that this was inherited as well.
Yeah, so that didn't come into play with the valbenazine label because that was approved through the more traditional way of a new molecular entity.
Exactly, right. So whatever showed up in the study specifically for tardive dyskinesia, not other studies or not from tetrabenazine. This is considered not so much a manipulation of tetrabenazine as a new molecular entity, as you mentioned. It's interesting. Another difference is valbenazine, there is not a recommendation to change the dose or adjust the dose for geriatric patients. I believe they had some of those in their studies.
Yeah, so that's interesting. I think we tend to dose more conservatively for older people.
Yes.
That's not necessarily a bad idea. We do have the flexibility in dosing to do that. So that's okay. But it also means, because they were included in the study, that we have the full array of dosing to use. And when we think about the major risk factor for developing tardive dyskinesia, the number 1 risk factor is age.
I see.
Yeah, so older people will have higher rates of tardive dyskinesia. If I gave a 60-year-old an antipsychotic, their risk of developing TD is 10-fold higher than for a 20-year-old. Now, the next most important risk factor is cumulative exposure. So, of course, give that 20-year-old an antipsychotic for 40 years, and they're really at high risk. And if they are genetically vulnerable to develop TD, they're going to run into trouble there. So you're going to run into the situation where many older people need a treatment for TD. The fact that these studies included them is good. It means we have a degree of confidence that they will work and they will be tolerable.
Yeah, I think it's wise, though, still. The tetrabenazine label says to use caution and monitor in geriatrics. I think that's probably wise with either of these medications, as you said. Now, let's talk a little bit about how do we focus on individualizing our treatment strategies, especially when we're thinking about medication selection.
I know we talked about how they're both similar and yet different. What we didn't talk about is how they are accessible to our patients. Both are sampled, so in our offices, we have both at hand. But there may be some differences in how the health plans that they belong to treat these different drugs. Some make it more difficult than others to prescribe one or the other. And, the path of least resistance is often the path that is traveled here when prescribing a VMAT2 inhibitor. And so that's what's going to probably influence the first thing I try. I also do have a conversation about how difficult it would be to take something once a day or twice a day.
Mhm,
And I do think about drug interactions. So
mhm,
that part of the conversation does take place as well. And if I do have a strong preference of one or the other for an individual patient, I will go to bat for them and get what they need.
mhm.
So that's the individualization part. I also want to individualize dosing, though.
Yes.
And I want to make sure that I optimize response. That usually means going higher. It means not being complacent. Now, how do I know I'm getting to where I want to go? I use measurement-based care, the AIMS.
Mhm.
The Abnormal Involuntary Movement Scale examination takes 5 to 10 minutes to do and gives you a quantitative picture of how dyskinetic they are, so to speak.
Mhm.
Now, if you don't want to do the full AIMS when you're following someone up, at least do the AIMS on those muscle groups you're specifically targeting and document that 4 went down to a 3 or down to a 2, or that 3 went down to a 2 or down to a 1.
I see.
Because then you can document efficacy and it'll tell you that score whether or not you should continue the titration.
Yes. There is some evidence from the longer term studies that there might continue to be some gradual further improvement even beyond the initial few weeks,
Yeah.
although we can't make that claim necessarily, but certainly that's been many people's experience.
Yeah, so that's the best news of all. It works acutely and continues to work.
Yes.
And when it continues to work, you'll have incremental improvements over time.
Mhm.
So you'll decrease that total AIMS dyskinesia score down to a very low amount after the course of a year or 2 or 3.
Mhm.
So that's great. This is not something that you only get the benefit at the beginning and then that's it. You do get continuous small amounts of improvement over time.
Well, this is something you mentioned earlier that you can start seeing some efficacy as soon as the first 2 weeks, but I always counsel patients and their families and caregivers that you may continue to see further improvement, particularly if we're adjusting the dose. So hang in there and stay with it.
Absolutely. And I tell them that, after a year's experience on this medicine, people have found degrees of improvement that are larger. And I think it's worthwhile to see how low your AIM score can go.
How low can you go? Okay,
Exactly.
limbo, yeah. Well, that's the good news long term, Les, but there's a little bit of bad news, and that is in these studies when the medication was withdrawn, what happened?
Yeah, so you stop the VMAT2 inhibitor and you'll see the dyskinetic movements return, at least most of the time.
Mhm.
And that's because VMAT2 inhibition is a management of TD, not a cure of TD.
I see.
So we need to, make sure our patients are aware of that. This is going to be a lifelong commitment.
Yeah, I think that's so important. People always ask you, how long do I have to take this medicine for? And I think it's fair to say at this point, we see it as indefinite, as chronic management, not unlike other chronic medical illnesses that we treat. Okay, so I'm really glad, Les, too, you brought up the access issue because that is the real world. And the fact is that as I've gone across the country and as you have giving talks, clinicians tell me all the time that one or the other of these has easier access or better coverage. And so sometimes that makes the choice. And as I mentioned, there's not any good a priori evidence on average that one is more efficacious than the other. So all other things being equal, it would be reasonable to start with whichever one is easier to get, let's say.
Yeah, I think step 1 in the steps to success is acknowledge you have TD in your practice and be on the lookout for that.
Mhm.
And when you see it, treat it.
Mhm.
The 8 guidelines for the treatment of schizophrenia were recently revised,
Mhm.
and the treatment for tardive dyskinesia was brought up to date
Mhm.
with the recommendation of giving a VMAT2 inhibitor to anyone who has moderate to severe TD,
Mhm.
but also to consider giving a VMAT2 inhibitor to someone with mild TD if they have any degree of functional impairment
Mhm.
and based on their preferences.
Mhm.
So this is very important because what looks mild to us
Mhm.
may not be mild to the patient. I've seen patients with a little bit of mouth movement, and I say to myself, this isn't so bad. I've seen a lot worse when I used to work at the state hospital.
Mhm.
But to that patient, it was the end of the world.
Oh.
They felt everyone was looking at them. They stopped shopping at the supermarket during the day because they didn't want to run into their neighbors. They went at 10 o'clock at night, and they stopped getting together with family and friends.
Yeah, so it's really important to really talk about the impact of this and not make the decision for the patient to not treat or that it's not worth treating. And I've certainly seen this too, particularly with higher functioning individuals, maybe with mood disorders, but we shouldn't assume that someone with schizophrenia is not sensitive to the social impact.
Absolutely. And although they may not realize that they are moving their limbs or lips or mouth in a way that you and I would be aware of,
Mhm.
they are aware that something's up
Yeah,
and that they're being treated a little bit differently.
they may notice people's reaction to them in other words. Yeah,
Yeah, so never assume. You know what happens when you assume, Andy?
I do actually. Bad things happen to you and I.
Yes. So this is from The Odd Couple. Remember that with Oscar and Felix?
Uh-huh.
For those in the audience who are from our era,
Mhm.
you'll know exactly what we're talking about.
Yeah. I guess I should say you and me would be more appropriate, not you and I.
Well, okay.
If I were to be literal. Okay, so what other things do we have to think about individualizing besides the choice of which VMAT2 inhibitor and the dose, which I love because, what we're seeing out there is a lot of people kind of maybe being a little timid with these drugs and using lower doses. And I like to say, don't set it and forget it. You need to continually readjust.
Absolutely. So TD also waxes and wanes.
Mhm.
So I don't, depend on exclusively one look. This is an ongoing process.
Mhm.
And it gets back to the idea, well, how often should I assess my patients for abnormal movements? It's actually every time they step into your office and you look at them. You don't have to do a formal AIMS, but you need to look at them. You look at them when they're waiting for you in the waiting area, and as you walk with them to the consultation room, and as they sit in front of you.
So that's another way that these APA guidelines were updated. We now are advised to look for TD at every clinical encounter with a patient on an antipsychotic.
Absolutely.
And that's certainly an update and a difference. And as you said, you don't have to do a full structured evaluation or formal AIMS at every visit, but that should be done at least once or twice a year, shouldn't it?
Yeah, so the guidance is if you're on a second generation antipsychotic, you do it at least once a year. If you're on a first generation antipsychotic, twice a year.
Mhm.
And if you're in a high risk group, you do it more often in
Mhm.
general. And what's a high risk group? Well, if you're older.
Mhm.
So what's old? It's 60 or older, sorry to say, Andy,
Yeah,
is older.
unfortunately.
And having a history of abnormal movements of any kind is a risk factor.
Sure. So if you see movements, of course, you might do it more frequently. I'll be honest, to me, that's a bare minimum. I typically try to do it at least twice a year for patients.
It's not a bad idea. And, if you're asleep at the switch, you're going to be blamed.
Yeah, it's certainly true. So other things, what else do we need to individualize? What else do we do with a patient with TD besides prescribe medication?
Well, I'd take another look at their antipsychotic and I'd take a look at whether or not they're receiving benztropine.
Oh, I see. Yes,
So let's go back to the fundamentals here.
yes.
I want to eliminate drug-induced Parkinsonism.
Mhm.
That's my mission in life. And I can do that by not using first-generation antipsychotics. So I consult to our local community's assertive community treatment team.
Mhm.
There's still lots of people on haloperidol decanoate and benztropine,
Mhm.
and they have both drug-induced Parkinsonism and TD.
Mm.
I cannot increase the benztropine, nor do I want to. So what am I left with doing? Well, I can switch the haloperidol decanoate to a second generation long-acting injectable
Mhm.
and take care of drug-induced Parkinsonism to a major degree.
Mhm.
I can start to decrease the benztropine,
Mhm.
and that'll help with the TD to a major degree.
Mhm.
And then over time, they're just on a second generation long-acting injectable. And usually they have no drug-induced Parkinsonism.
Mhm.
And they're at a dose where it controls their symptoms sufficiently. They still have TD, but now is the time to treat that TD with a VMAT2 inhibitor.
I see.
So that's my reasoning there. And that's how I individualize treatment, not only in terms of their VMAT2 inhibitor and doing that route, but also paying attention to their underlying antipsychotic drug regimen and the elimination of benztropine whenever feasible.
Well, I think this notion of minimizing or getting rid of anticholinergics is so important because I was trained that they're for use in a short-term situation, perhaps. Well, certainly with the first generations, a lot of people would start them concurrently. You're sort of wedded to them. But with the second generations, they're not always for long-term use. As you said, you can lower the dose, adjust the dose of the second generation, use one with lower binding affinity for D2. And the consequences of long-term use as we get older, of course, is some very bad anticholinergic side effects, right?
Yeah, I think the worst one is cognitive impairment and impairment of memory. And our patients who are receiving antipsychotics generally have poor cognition to begin with. We're just making it worse.
Exactly.
So I think that's impacts on functioning to the greatest degree. But you also get urinary retention as well as constipation. And then this is a real issue, especially as one gets older. And it doesn't take much in terms of anticholinergic load with an older person to be prone to delirium.
Yeah, I have many patients who complain bitterly of constipation, and certainly older males, as we well know, there's issues with the prostate and urinary retention. So I think you and I are, to some degree, on a public health mission to get people to really rethink their use of anticholinergics, and specifically benztropine is the one that people seem to use the most.
Yes, I think it's a real problem. It's a knee-jerk reaction to add benztropine to an antipsychotic. And actually, if you look at the literature from the days gone by, it was never a permanent thing. It was always, you do it at initiation, then you stop.
Yes.
But old habits die hard, and people continue to use benztropine more or less indefinitely.
Right. The other thing that you mentioned, too, besides focusing on anticholinergics, is really taking a good look at all of the medications they're taking. And I sometimes will ask a patient to fill up a shopping bag with every pill bottle in their house. And sometimes you're very surprised what you see people are taking and things you didn't know they were taking, or they're taking a bottle that's labeled with the generic name and another bottle labeled with the brand name. No, it's different. So I think really looking at the whole picture is very important.
Yeah, that's a great tip. I ask patients when they're coming in for evaluation to bring all the medicines that they take,
Yes.
including the over-the-counter, and
Yes.
I take a look at all of them. And as you said, sometimes they have a bottle labeled Ativan and another labeled lorazepam, and they take both.
Yeah, they don't know the difference. Yeah, so I think this idea of individualizing, we need to think about, especially for TD, first is to understand the individual's pattern of movements and the impact of those movements, and then try to select, ideally, a VMAT2 inhibitor based perhaps on access, but also on some of these other issues that we've talked about, and so the practicalities of how they're used and whatnot. Drug interactions, of course, are very important, and that's another reason you want to know all their medications. They may be medicine there that could have an interaction with one of these. And then looking at also trying to simplify their medication regimen, but also understanding their medical picture and medical conditions as a whole. And then, of course, try to individualize that dose and don't set it and forget it, really push it. So, Les, believe it or not, we're coming to the end of our hour. This certainly went by quickly. Do you have any final thoughts, anything else you'd like to add?
I think, as we mentioned, we need to acknowledge that TD exists, and for a long time we've tended to ignore it. Now we have treatments for it that work really well and that are well tolerated. And it would be a shame, really, for our patients if we didn't take advantage of these advancements in treatment.
I certainly agree. And, the American Academy of Neurology also updated their guidelines in 2018 to recommend the VMAT2 inhibitors as really must be considered because the evidence is so strong. And you and I both know from practicing in the pre-VMAT2 era how frustrating it can be to not be able to help our patients and offer them something effective like this. Okay. Well, with that, I want to say thank you so much to the audience. I hope that this has been helpful to you in thinking about your treatment of TD. I certainly agree that the first step is to look for TD and to recognize it, and then to learn how to individualize and treat it appropriately. So I'd like to thank Les Citrome, Dr. Citrome, very much for joining me today. Thank you, Les.
Well, thank you, Dr. Cutler. It's always a pleasure working with you.
Likewise. So please stay tuned. There are other podcasts in our series here. There are CME podcasts and non-CME podcasts. And for more information about our educational offerings, you can go to www.neiglobal.com. Thank you so much. This is Andy Cutler signing off.
Thank you for your participation in this NEI CME podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to go online and print your certificate. This concludes the CME podcast presentation.